Hi, my name is Christine Fox. I'm a pediatric vascular neurologist at the University of California, San Francisco, and I'll be presenting today with Dr. Sarah Lee, also a pediatric vascular neurologist at Stanford Children's Health. And today we'll be talking about the future of pediatric stroke management. Neither of us have any financial disclosures. However, we will be talking about hyperacute stroke treatments in children that are not FDA approved for children. A pediatric stroke is categorized as perinatal if it occurs between birth up to 28 days after birth. And by convention, a childhood stroke occurs between 28 days of life and 18 years. The incidence of a childhood stroke is about 4 per 100,000 per year, which roughly translates to 5,000 new cases in the United States annually. And about half of these are ischemic. And today we're going to be focusing primarily on childhood ischemic stroke. Although stroke is less common in children compared to adults, a stroke that happens during childhood can still have major consequences. Stroke is among the top 10 causes of death in young people, and among survivors, about 2/3 will have persistent motor deficits, and about 1/3 will develop post-stroke epilepsy. And this proportion is even higher in children who are younger at the time of the stroke. Lasting deficits in cognition, language, and executive function can disrupt a return to school. And also in the long term, they make employment and independent adult living more challenging. The financial effects of a childhood stroke also might be greater compared to the comparable adult stroke. The 5-year average adjusted cost of ischemic stroke in childhood is probably about 3 times higher than the estimated costs of ischemic stroke in a person who's older than 65. And for all these reasons, an intervention that either could reduce or eliminate disability in children with stroke would have a major lasting effect on individual children and their families and on society. In the past 2 decades, there have been major advances in hyperacute ischemic stroke interventions that can reduce disability in adults. But one of the major barriers to similar interventions in children is that pediatric stroke is under-recognized and underdiagnosed in that critical early window after a stroke. And the delays in stroke recognition can occur at every level. Public awareness among caregivers, parents, and even pediatricians is relatively low. Stroke symptoms might not always occur with that abrupt onset. That's the hallmark of an ischemic stroke in an adult. And about 1/3 of children report a headache or a seizure or have a seizure at the onset of a stroke. And this makes distinguishing a stroke from a stroke mimic more complicated. And then finally, children can sometimes just be difficult to examine, and that sometimes can delay recognition of a new deficit. Even when a stroke is suspected in a child, confirmation of that diagnosis is often delayed by barriers to getting rapid neuroimaging. Many hospitals and medical centers don't have a pre-established clinical pathway for evaluating children with suspected stroke or imaging protocols that can rapidly identify a large vessel occlusion or select children who might benefit from a hyperacute treatment. So the future in pediatric stroke management includes steps to improve public awareness and to improve childhood stroke recognition among first-line providers. Also, to create systems of pre-hospital triage. A future network of care for pediatric stroke includes establishing connections between community hospitals and specialized pediatric stroke care centers. At a pediatric stroke center, a coordinated alert system is needed that can readily activate a stroke team. And a pediatric stroke alert pathway should include optimized MR and CT imaging protocols that can be obtained really quickly and also include vascular imaging. The future in pediatric stroke management means addressing barriers to rapid care at every level so that we have the opportunity to provide early interventions after a stroke occurs in a child.
What do we know about treating stroke and what data do we have? So obviously in adults, we have a wealth of randomized controlled trials that tell us who to treat and in what time window and with what. And it would be great if we could just extrapolate those guidelines to children, but of course we cannot do that. Children are not little adults. For one thing, the stroke etiologies in childhood stroke are very different than adult etiologies. Children are not susceptible to atherosclerosis or atrial fibrillation as much. Arteriopathy is the most common etiology of stroke in children, which happens less often in adults. Stroke mimics are more common, as Dr. Fox alluded to, and really no intervention is without risk. So in particular, children with large vessel occlusion who may be critically ill, the risks of treatment with treatments such as thrombectomy may be very different in a young child and must be balanced with potential benefits. Arteriopathic seno-occlusion can be very difficult to distinguish from embolic large vessel occlusions, and those may not benefit from reperfusion. So we need to think very carefully about the children that we're treating with these adult treatments. We have no randomized controlled trials in children to help guide these treatments. And this is just a statement from the American Heart Association and American Stroke Association saying, in the absence of pediatric clinical trial data to guide treatment decisions, hyperacute therapies for childhood stroke remain controversial. So what do we know? So for anything we are using off-label, we want to know, is it safe and how effective is it? So what do we know about IV alteplase in children? So to some extent, we extrapolate from the young adults who received IV TPA in the original NINDS trial, which showed us that 6.4% of older adults, elderly adults, develop symptomatic intracranial hemorrhage, which is the feared complication after TPA, while none of the younger adults encountered a symptomatic intracranial hemorrhage. There is some interesting in vitro data to suggest that thrombi in children may be more loosely woven and thus more susceptible to IV TPA in mouse models. And we wonder if the effective dose of IV alteplase should actually be higher in children based on what we know about the developing fibrinolytic system in children. So children have lower levels of endogenous baseline free TPA, higher levels of plasminogen activator inhibitor. So the dose that they require for clot busting may actually be higher, but this remains to be determined. There was a study that investigated this. It was the continuation of an NIH-funded study called TIPS, which looked at 93 children and with arterial ischemic stroke and who received TPA. Unfortunately, that trial was closed due to lack of accrual, but we obtained a number of follow-up information about 24 children who received TPA, none of whom encountered a symptomatic intracranial hemorrhage. So potentially this could be a very safe intervention. As Dr. Fox alluded to, however, the time window, there are lots of delays in diagnosis to treatment of childhood stroke, thus the 4.5-hour time window for TPA is challenging. Thrombectomy, of course, is a very compelling option in children. Now in adults, the guidelines have extended the time window out to 24 hours from last known well in a select group of adult patients with large vessel occlusion. And pediatric stroke neurologists were very excited about this change. So because we do have these delays to diagnosing children, a 24-hour time window for treatment is much more feasible than a 4.5-hour window. What do we know about mechanical thrombectomy in children? So there have been an ever-growing number of case series and case reports that tell us that, that suggest that there's an excellent safety profile, but there are some things to really consider. So obviously, very young children may have smaller arteries that may limit catheter size. Operators, neurointerventionalists performing these procedures may not be comfortable treating young children, and that may affect the outcome of the procedure. There are contrast, fluid, and radiation dose limitations that may be different for children than adults. And finally, as I discussed before, arteriopathies such as moya-moya disease or focal cerebral arteriopathy, which is a distinct childhood stroke etiology, may not be as amenable to revascularization as an adult occlusion. The Save Child study is probably one of the largest retrospective cohorts out there looking at thrombectomy in children. It investigated 73 children at 27 European and US centers. They reported really excellent recanalization rates, a very low rate of complications that were comparable or better than pooled adult trial data. And so this does seem like it's a promising therapy for children. But how are we selecting children for thrombectomy? So despite the fact that we have many case series that report excellent outcomes, these are of course limited by retrospective design and bias. And it's really interesting to note that a couple of these studies, a handful of patients in each study report a patient or several patients who go on to develop a really large stroke, which suggests either that the stroke was already very large to begin with, or that the stroke grew so quickly that it completed before they were able to open up that vessel. So begging the question of how are we selecting these children, and is there a better way to think about selection criteria? So this is kind of where the future of childhood stroke management lies. So certainly we need great systems of care, multidisciplinary cooperation between neurointerventional radiology, neuroradiology, neurosurgery, adult stroke neurology. So a lot of different crosstalk between specialties is critical. Transfer pathways and metric tracking to improve outcomes and times for these patients. And of course, future directions, hopefully incorporating some of the pediatric treatments in the AHA Get With the guidelines, as well as utilizing international groups such as the International Pediatric Stroke Study and Organization, which help raise awareness and perform research studies in this unique population.